Professor Saša Živković. He's from Pittsburgh, but he graduated from the University of Zagreb School of Medicine, and then later he did his postdoctoral fellowship at NIH. He's a professor of neurology at the University of Pittsburgh School of Medicine. His research and clinical interests are peripheral neuropathy, neurologic complications of systemic amyloidosis, quality improvement and quality control of neuromuscular clinical care. He's a co-author of the AANEM quality measures in electrodiagnosis, carpal tunnel syndrome, and this is the topic of his today's talk. Saša, please.
Thank you, and thank you for the organizers for the invitation. And I'm going to talk to you about quality measurement in electrodiagnosis and recently introduced quality measure set for carpal tunnel syndrome. So quality and value in healthcare have been described in many different ways, but generally quality of care is defined by the outcomes, and it is associated with adherence to the guidelines. And we have heard a lot about guidelines in electrodiagnostics from our previous speakers. And the value in healthcare is defined by the outcomes relative to the cost. And how good are we with quality of healthcare that we are providing? So 17 years ago, a large study was published in New England Journal of Medicine that was looking at the quality of healthcare provided to almost 7,000 adult participants among 15 different areas, and the percentage of recommended care received varied for 18% for counseling or education to 73% for encounters, and we can definitely do better than that. And therefore, we have to strive for continued improvement of the quality in the healthcare, and we need to measure how good are we in maintaining that quality, and we have to control the quality. So the major aims of quality control are improving outcomes, efficient use of resources, and controlling cost, and promotion of accountability. And outcome improvements should be patient-oriented, and they should be meaningful. So right now, the future of the quality control is associated with an integrative approach to high-value healthcare, but this may be sometimes constrained to specialty boundaries, and I'll touch on that a little bit later as well. So we need high quality measures to know how good are we at providing high quality healthcare. We need to be able to measure it, and quality care can be measured by structure, process, and outcome measures. So structures measures look at the evaluation of characteristics of clinicians and healthcare systems. Process measures look at the characteristics of the encounter between the clinician, and it's often used as a surrogate outcome measure. And the carpal tunnel quality measure set uses process quality measures. And we can also look at the outcome quality measures that are looking at the patient's health status after the encounter. And one important advantage of process measure is that they may also facilitate root cause analysis and help us to identify gaps in the healthcare. So when we are talking about development of quality measures in clinical practice, we have to make sure that these quality measures are usable and applicable for most practitioners in different settings and in various populations. And we should be able to distinguish acceptable and unacceptable variation of care. Quality measures can be used internally or externally, for instance, by payers when deciding on reimbursement, but I'm not going to talk about that, as it would open very, very different discussion afterwards. So why did we go for carpal tunnel? Well, carpal tunnel is the most common entrapment neuropathy, which affects up to 4 to 6% of population. It is one of most common referring diagnoses for electrodiagnostic testing. So most of neurophysiology practitioners should be able to use this quality measure. It is work-related in up to 2/3 of cases. It's associated with substantial loss of productivity. And in US alone, there are at least 500,000 carpal tunnel release surgeries annually. When we look at patients with carpal tunnel, 1/5 of patients that present with numbness and tingling can be diagnosed with carpal tunnel syndrome with electrodiagnostic studies. In both electrodiagnostic studies and imaging studies, including ultrasonography and MRI neurography, may have high specificity and sensitivity in the diagnosis of carpal tunnel syndrome. So therefore, Quality Improvement Committee of the American Association of Neuromuscular and Electrodiagnostic Medicine developed the quality measure set for evaluation of quality of electrodiagnostic testing in patients who are referred for evaluation of carpal tunnel syndrome. These measures are looking at the electrodiagnostics, that whether electrodiagnostic evaluation is adequate technically, whether electrodiagnostic data is interpreted adequately, and how often is it used for patients undergoing carpal tunnel surgery. So the first measure is looking at the essential components of electrodiagnostic evaluation for carpal tunnel syndrome. And it's looking at the percentage of patients who were referred for evaluation of carpal tunnel syndrome who had adequate electrodiagnostic testing with minimum requirements as defined by practice parameter by ANEM, including median sensory and distal motor latencies and another sensory and motor nerve. So when we are looking at this percentage, we have to exclude patients who had incomplete study that were stopped at patient's request, or the studies where the electrodiagnostic physician recognized an alternative diagnosis. So when we are looking at these quality measures, we always have to make sure that they're useful and they should promote improvement of healthcare outcomes. So there was an important study that was recently published by Terry Knuckles and colleagues that looked at exactly this. And in their study, when they were looking at work-related carpal tunnel and essential components of electrodiagnostic evaluation for carpal tunnel syndrome, they have found that 78% of electrodiagnostic reports in their study conformed to this quality measure. And the importance of this study is also showed that the high quality electrodiagnostic testing is also associated with improved outcomes after the surgery for carpal tunnel. And that's another proof that high quality care really does improve the outcomes. The second quality measure is looking at the adequate maintenance of hand temperature during electrodiagnostic testing. That should be maintained at or above 32 degrees Celsius. And I don't have to talk to you about the nerve conduction studies and the impact of cooling on these nerve conduction studies. And the only exception for this measure will be the studies where there was a documented inability to maintain adequate temperature despite attempts at warning. So, and we look again at the study of Knuckles and her colleagues. And in that study, actually, it shows that only 26% of studies actually documented adequate temperature maintenance during testing. And this is one important caveat when we are talking about quality control. If something was not documented, it's like it has not happened. And I would believe that that would explain a large portion of this electrodiagnostic reports who did not have documentation of skin temperature measurement, but we cannot tell that for sure. The next measure actually looks at the percentage of electrodiagnostic reports which which provide the diagnosis of median neuropathy at the wrist that was supported by electrodiagnostic data. And once again, we will exclude from this measure electrodiagnostic reports that show a different diagnosis and incomplete studies that were stopped at patient's request. Additionally, patients with diagnosis of severe median neuropathy, this diagnosis should also be supported by adequate data. And once again, we will exclude the patients with electrodiagnostic studies showing a different diagnosis or with incomplete studies. And this is a very important measure because severity of carpal tunnel syndrome informs treatment options, and severe axonal loss may require urgent surgery. And once again, the study by Nichols showed very low compliance with the interpretation of diagnosis of severe carpal tunnel syndrome, and that can be to some part attributed to the fact that different definitions of severe carpal tunnel syndrome have been recommended in the literature. The third and final quality measure actually covers preoperative electrodiagnostic testing for carpal tunnel syndrome. And this measure is looking at the percentage of patients who are undergoing surgery for carpal tunnel syndrome who had electrodiagnostic testing within 12 months prior to surgery. And we will exclude from this quality measure all the patients who did not have electrodiagnostic testing, but who had an alternative confirmative test, such as ultrasound or magnetic resonance imaging. And we will also exclude the patients who have declined electrodiagnostic testing. And this is an important measure because it actually opens the door for multidisciplinary quality control, because obviously electrodiagnostic practitioners are not going to be the ones who will perform carpal tunnel release, and there is still some pushback among hand surgeons against electrodiagnostic testing in some patients with carpal tunnel syndrome. So how often is carpal tunnel release preceded by electrodiagnostic testing? So this study by Sears and colleagues looked at the medical records of almost 63,000 patients that underwent carpal tunnel release, and only 58% of them underwent electrodiagnostic testing prior to surgery. And in this study, of course, they have not reported the percentage of patients who had imaging studies prior to electrodiagnostic testing. I'm sorry, prior to carpal tunnel release. So the percentage is a little bit higher. And at the same time, one of the big reasons why some of the hand surgeons are justifying not pursuing electrodiagnostic testing is a delay of surgery, which I think we would agree that in most patients with carpal tunnel syndrome, urgent surgery is not the path that would be pursued, but it's something that has to be sorted out within the medical community between us electrodiagnosticians and hand surgeons together to identify which are the patients who will benefit the most from electrodiagnostic testing prior to carpal surgery, and how can we identify them. So right now, I hope that I was able to convince you to some extent that adherence to guidelines and high quality care are associated with better outcomes, and the development of ANEM quality measure set for carpal tunnel syndrome is an early step in promoting high quality electrodiagnostic testing that will need to be followed, and quality measures need to be continuously validated and we have to modify them as needed. We are facing significant future challenges, including implementation and evaluation of quality measures. And we are also looking at the electronic medical records that should help us to collect adequate data to facilitate implementation and evaluation of quality measures. We should follow this with development of new quality measures. And the third quality measure of our carpal tunnel measure set may open the door for integration of electrodiagnostic quality measures and policies into multi-specialty quality control. And at this point, I would stop, and I would be happy to take any of questions. Thank you for your attention.
Thank you very much, Professor Živković. So at the moment we have one question, and the question is, would carpal tunnel syndrome electrodiagnostic testing be completely replaced with median nerve ultrasound technique anytime in the future?
So there are advantages to both imaging and to electrodiagnostic testing. So ultrasound, median nerve ultrasound provides anatomic anatomic explanation of and the anatomic demonstration of median nerve entrapment, but at the same time, electrodiagnostic testing may help us to identify some of the mimics of carpal tunnel syndrome. So to make it simple, the median nerve ultrasound will provide you an answer yes or no, and the electrodiagnostic testing may answer the question why. And I see them more as complementary tests more than anything else.
Thank you very much. If there are any more questions or comments, we have some time. Maybe you can just wait for a couple of minutes. Are there any other quality measures that you're preparing, not just the carpal tunnel? Is this a way to go to look at other diagnoses?
So right now, so one thing that I didn't touch on is the use of quality measures in reimbursement and use of the quality measures on the in the kind of integration of healthcare and providing high value healthcare. And the quality measure set for ulnar neuropathy will probably follow, but we will see. It's a situation that's gradually developing. The biggest question is, what kind of a quality measure are we going to use if we are going to really, if the target is going to be integrated healthcare, our quality measures are going to be a little bit different. They will not be constrained by individual specialties, and I think that's time will tell. We will see. Things can go in different directions at this point.
So what do you mean by integrating
so multidisciplinary care? Yes. So multidisciplinary care that would actually evaluate care provided by physical therapists, electrodiagnostic technicians, hand surgeons, on the example of carpal tunnel syndrome. So for some other conditions, for instance, for ALS, it'll be easier to look at multidisciplinary care as there are many multidisciplinary issues in the patients with severe neuromuscular disorders like ALS. Their pulmonary care, neuromuscular care, rehabilitation, and so on. So one big problem
Thank you,
yes, one big problem in healthcare is the spiraling cost of healthcare, and that is one area where quality care should help us to provide high value care, since resources are of course limited. And so when we are looking at carpal tunnel syndrome, one thing that will illustrate that is the loss of productivity. So it's not directly impacting so much the cost of healthcare, but the loss of productivity is also indirect cost of healthcare that's provided. So we are looking at this we should all look at this from all different angles, not to mention the use of some of the newer medications that carry very, very high cost and sometimes can be used improperly. And so quality of care is not a very exciting topic, but it's an important thing that we should keep in mind, and that should help us. So as Vincent Tranchitella was talking about all the things that we look at to make sure that things are done right, quality measures are telling us how good we're at doing the right things. So we can sometimes correct our policies, and hopefully leading to improvement of healthcare outcomes.
Okay, thanks. Sasha, we have another question about something that we all come upon. So after failed CTS surgery, do you suggest repeated EMG, neuroconduction study, or median ultrasound?
So right now some of the studies suggest that 10 to 15% of carpal tunnel release surgeries will have suboptimal outcome. But I think that the percentage of failed surgeries is much lower than that. And I once again think that we should really decide this on case-by-case basis, because sometimes electrodiagnostic testing will change after carpal tunnel surgery, especially if the nerve injury was related to neuropraxia, but with more significant axon loss. We don't have a very good data to tell us how do we approach these cases in general. So I think we should go from case to case basis and use both ultrasound and electrodiagnostic testing. Ultrasound will provide the information, will provide the anatomic information, but it may be more helpful in patients with a failure of carpal tunnel release than electrodiagnostics. But I think there is still a role for electrodiagnostic testing as well. One area where I think that the electrodiagnostic testing will take a backseat to ultrasound are patients with polyneuropathies, because in patients with polyneuropathies, so like 30% of patients with Charcot-Marie-Tooth syndrome will have carpal tunnel syndrome. And when we look at that, we are usually trying to look at the median nerve entrapment out of the proportion to the severity of neuropathy. But ultrasound really provides you evidence of focal nerve entrapment in a patient like that. And of course, MRI will give you even nicer pictures, but ultrasound is really helpful in that type of setting.